Okay, good evening, everybody, and thank you very much. Thank you very much to join us. And today we are going to have an Asian cardiovascular disease series of web seminar 2026. Today we are honored enough to have Professor uh, Ni
It's a Nikola Bulj.
Nikola Bush. Nikola
Yeah,
Bush.
you are doing great. Yeah.
Yes, so thank you very much. And he's a professor of the associate professor of the cardiology School of the Medicine, University of Zagreb, and cardiology clinic, University Hospital Center of State, myostonic Zabraka, Croatia.
It's good. Yeah.
Yeah, and he is a cardiologist and associate professor with the clinical leadership in the echocardiography and the cardiac hemodynamic specialist. And can you have a slide about the introduction of the professor? And he his research interests are the echocardiography and multimodal cardiac imaging, hemodynamics, and the valvular disease and myocardial disease and cardiotoxicity and oncocardiology, drug safety, as well as the acute pulmonary embolism biomarkers and imaging in prognosis. And he has many publications, and he has more than 30 peer-reviewed scientific papers in cardiology, including myocardial infarction, predicts, pulmonary embolism imaging, and valvular pathology. And he also contributed to the textbook of the clinical and the clinical guideline in the cardiology. And today he will talk about the beta block in 2026 and update. And we also have an panel, another professor have an talk. He is the Professor Xiaoguang, and Xiaoguang. I'm sorry. He she is an professor from the People's Hospital of the Xinjiang Autonomous Region. And we have another panel discuss with Dr. Guo and Dr. Guo and Dr. Zhang, and from the affiliated Cardiovascular Hospital of the Xiamen University, and the from the 80th affiliated hospital of the Shenzhen University. So now, Professor Nikola Bulj,
Thank you.
please,
That's a great one.
please.
Thank you.
Thank you.
Thank you, Professor. Thank you for your warm welcome. I'm really privileged. I'm really honored to be with you. Thank you for having me. Good evening, everyone. Good afternoon from here, from Zagreb, from Croatia. I hope that the weather in China is better than here. It's coming heat wave again. As you can see, I'm in a hospital. It's 1 p.m. In our time, and I'm very glad and privileged to be here with you. And I would like to share some insights on the updates regarding the beta blocking therapy in the 2026. And I hope we will cover some news and some differences, if we call these things differences, between the clinical trials in the so-called Western country and all over the world, especially from my perspective, Far East, like China or and other countries. So I hope that you can see my slides. It's called Beta Blockers in 2026, an update, and it will be a critical reappraiser of contemporary trial evidence and guideline recommendations. I'm completely sure that as here in Croatia is in EU, there are lots of clinical inertia regarding beta blocking agents in treating hypertension, heart failure, arrhythmias, whatever. But when you look at the evidence and the literature, you will find that lots of things that we take for granted are not covered by the randomized clinical trials or real-world evidence. So we have some news from the 2024 until nowadays, and I will try to go through it through my presentations. So I will cover very briefly molecular pharmacology of the beta blocking agents. Are they all the same? Of course, we will go very shortly from the hypertension point of view. We will have ischemic heart disease in the lecture, which will follow mine, but I will cover some of these things regarding the post-infarction therapy and the chronic coronary syndromes. Of course, we will cover atrial fibrillation with very short and brief informations. We have a huge step forward in treating heart failure patients with reduced and mildly reduced ejection fraction. And of course, we will have some special populations like respiratory disease, cardio-oncology, erectile dysfunction, perioperative risk, and elderly and especially frail patients. So this is from our prior knowledge. We know that there are lots of kinds of beta receptors, beta 1, beta 2, and alpha, and we can stop the mechanism by attacking the beta 1, like with bisoprolol, nebivolol, or metoprolol. We can do it unselectively with carvedilol, propranolol, and everything. We know that, and we don't know to cover this in general. So when you look at the comparative pharmacokinetics of agents in clinical use, then you will see that there is some differences between drugs. There is differences between bisoprolol, for example, and nebivolol and metoprolol in the metabolism and pharmacokinetics. So if you look at the metoprolol and nebivolol, you will see that there is a huge hepatic clearance of the drugs during the cytochrome pathways, which is not the case with the bisoprolol. Also, if you look, for example, in your populations of patients about CYP2D6 activities, then you will see that almost 50% of people from the China or the Far Eastern country will be poor or moderate metabolizer. So if you look from the perspective of the clinical usage of these drugs, bisoprolol is a very effective drug with patients with renal insufficiency, and especially in the patients in your countries. When you look at the guidelines, then we will see that there are some differences with guideline endorsed indications from 2024 till 2026. And these are the usual indications for the beta blocking agents, like heart failure with reserved ejection fraction post-MI with reduced and preserved or mildly reduced, hypertension, chronic coronary syndrome, atrial fibrillation, and the respiratory obstructive disease. And you can see, if you can see ESC or AHA guidelines, then in the post-MI patients with the ejection fraction higher than 40% and hypertension, there is an indication, but the level of evidence was downgraded from the A or lower to B and something like that. Nowadays we know that patients with post-MI patients with normal ejection fractions will not benefit from the beta blocking treatment. This is some kind of history. Why in hypertension, let's start with that. Why in hypertension patients we do some kind of clinical mechanistic inertia? That was due to atenolol times from the early ages of these things. We know that other beta blocking agents are more, that other antihypertensive, agents are more effective in the treating hypertension. And there is some kind of discrepancy when you look at the atenolol between central aortic pressure and pulse wave velocity, which is not seen in the patients, for example, treated with bisoprolol, we have greater central aortic pressure reduction when compared with atenolol. These are the guidelines for the arterial hypertension, and you can see, if you can see, European Society for Hypertension, Society of Cardiology, American, UK, and of course China guidelines, then you can see that there is some discrepancy over the decisions whether or not to use the beta blocking agents as the hypertensive. So in your China guidelines, it still looks like the ESH guidelines from 2026. Okay, we have 5 types of drugs we can use during the treatment of the hypertension patients, but we can choose between them. But in the European Society and American guidelines, they recommend not to use beta blocking agents as a first-line treatment in our patient. When we look at your Chinese guidelines, that there is some rationale to do a beta blocking treatment in the patients with arterial hypertension, because there is clinical signal that elevating resting heart rate is documented an independent risk factor for your cohort of patients. And of course, that sympathetic overactivity is a prominent phenotype in younger patients with hypertension. This is usually the patients that we also treat with beta blocking agents in a younger age. And of course, lots of these patients, they do have coronary artery disease and heart rate related indications with highly prevalent comorbidities in the treated population in the China and the surrounding countries. So we can use the beta blocking agents in the treatment of hypertension. We can focus on the beta blockers such as bisoprolol, which is very effective. And as I already told you, not metabolized by it's a 50-50 metabolism over the hepatic and renal pathway. Good half time of the drug, and it can be used as an add-on therapy in treating hypertension, and sometimes as a first-line therapy is a younger patient with the increased sympathetic activity. When we go to the post-MI therapy, you can see that we have very old trials, and patients were treated regardless of left ventricular ejection fractions. Nowadays we know that we need to calculate ejection fractions to our patients in order to make a decision whether or not are we going to treat the patients. And of course, these trials were driven in the times where there was no systemic reperfusion, no high sensitivity troponins, no modern therapies. So this is a little bit obsolete. But there was clinical inertia to treat post-MI patients with beta blocking agents, because we thought, of course, if we reduce the sympathetic activity, the patients will do better. But nowadays we do have new results, and I believe that it will be covered more in detail in the following presentations. We do have reduced AMI patients with which was asked the question: do we need to put patients in an open label manner? We need to with STEMI or non-STEMI, and preserved ejection fractions on beta blocking agents. They use the metoprolol, they use some bisoprolol. But you look at the results. The results show no difference between beta blocking treated and beta blocker untreated patients. So this is something new. Now we know that if the patient post-MI have a normal ejection or preserved ejection fraction, it is not mandatory to put him or her on the beta blocking agents. The other trial was a reboot trial, which was also more than 8,000 patients, and of course it looked. This was showed last year on the ESC Congress in Madrid, and it was even more courage, I would say, because they put a superiority endpoint, but it was not shown. Also, patients treated with and without beta blocking agents and preserved ejection fraction, there was no difference between those investigated groups. And of course, when you put all these things into meta-analysis, so we are talking about REBUTE, REDUCE, AMI, beta-mid, DAM block, and capital randomized clinical trial from Japan, with a relatively smaller number of patients, then you see that patients with normal ejection fraction, and this is new, this is update for 2026, will not benefit from beta blocking agents if they suffer myocardial infarction, once again with normal ejection fraction. But what if we have mildly reduced ejection fraction? If you analyze the data, and these are the patients with ejection fraction between 40 and 49%, then you will see very prominent benefit from treating these patients with beta blocking agents. I believe this is because we are basically treating the heart failure in this cohort of the patients. But if you have a patient below 50%, then after myocardial infarction, then the usage of beta blocking agents such as bisoprolol would be very, very advisable. If you look at the sex-specific heterogeneity, this is only a trial from the REBUTE data, not from the meta-analysis. Then you will see that the women, they had such a worse outcome if treated with beta blocking agents. But in this only one trial, the baseline for women, they were older with a higher comorbidity burden and lower rates of guideline concordant therapy relative to men. When you put this in the meta-analysis, you will not find differences between the gender. Of course, these trials, they do have some shortcomings. They are all open label design. They are not homogenized by the population wise, and of course there are some discussion between discontinuation and of course a crossover. So this is when we talk about post-MI therapy, this is how things in 2026 look like. If you have a patient with post-MI with reduced ejection fraction, beta blocking agents is completely indicated class 1. It's a part of the 4-pillar strategy for the treatment of the heart failure. If you have a mildly reduced between 40 and 49%, we have some data supporting the usage of beta blocking agents. But if you have preserved uncomplicated MI, we do not have demonstrated benefit between these two, between patients treated and not treated with beta blocking agents. Of course, if the patient is symptomatic angina, symptomatic arrhythmia, or you need some kind of rate control, then you need to consider it on the individual basis in your patients. Now, there is another very interesting topic. When do we need, or should we need, to stop the beta blocking treatment after MI? There are two trials, which is ABIS from France and SMART Decision from South Korea, also applicable probably worldwide. And the question was, should we stop the beta blocking agents after 1 year post MI? Of course, we have very diverse data. SMART Decision, which was open label, non-inferiority, but with better, I would say, better inclusion criteria and better hard outcomes. They showed that that you can safely stop the treatment, and that it can be done. Otherwise, the ABIS from France, they showed no quality of life benefit from interruption and resting heart rate consequently. So you can do it. It's not forbidden, but you should be clinically oriented while deciding what to do on it. I think the SMART Decision from South Korea a little bit better designed trial, and we can trust those results. So let's move on to the heart failure. We know that nowadays we have lots of trials behind us with bisoprolol, metoprolol, and carvedilol in the treatment of patients with heart failure, and we have very strong evidence that patients with heart failure with reduced ejection fraction will benefit mortality wise from this treatment. So we have beta blocker, bisoprolol, carvedilol, metoprolol, metoprolol succinate, and nebivolol as one of the 4 pillars in the treatment of these patients. And of course, in the light of the strong HFs trials, which moved the paradigm, now we know that we should start all of these drugs during the hospitalization, and then we need a quick and very short periods between checkups in order to maximize these dosage to maximally tolerable to our patients. So we don't have questions about beta blockers in the indications of HFrEF, but we do have a problem. If you can see this slide, only less than 20% of the patients are on the beta blocking agents from the strategy recommended by the guidelines. We can discuss this. Some people in my hospital, for example, they do believe that you don't want to reduce the heart rate so much in order to provoke the further cardiac decompensation. I think this is also clinical inertia, and I think we need to improve our clinical practice and increase these numbers to treat our heart failure patients. With the HFpEF patients with preserved, there is no demonstrated mortality benefit. So we know that from for the patients also for post-MI, which I already told, and in the patients with mildly reduced ejection fraction, we can individualize the treatment with beta blocking agents. Of course, we need to take into account is there atrial fibrillation or symptomatic coronary artery disease. Then if there is, we should apply these drugs even to the patients with moderate ejection fraction. Okay, let's move to atrial fibrillation. You know that the beta blockers are the drugs which are used to control the rate in these patients, and they are clearly superior to dihydropyridine calcium channel blockers like verapamil, and we have better resting rate reduction. We have superior control of peak exercise heart rate. We have affirmed patient sub-analysis associated with better mortality rates, and of course, it's a mandatory in beta blockers, especially bisoprolol, and it's the most prescribed drugs in my one of the most prescribed beta blocking drug in my country. It's a mandatory in patients with atrial fibrillation and heart failure with reduced ejection fraction. So this is relatively old news, but we need to cover it. Okay, so, when we're talking about the chronic coronary syndromes, we have some conflicting data regarding the usage of beta blocking agents in these patients. So if you look at the patients like REDUCE-AMI trials, I think that we have they may help. Beta blocking agents may help, but we don't have very, very strong evidence for that. So this is why the level of evidence downgraded from A to B. We need confirmatory outcome trial to make clear completely. In my country, in our clinical practice, we do still apply lots of beta blocking agents, namely bisoprolol, to our stable coronary artery disease patients. But we have some publications from JACC from 2023 that from out of 28,000 people with stable coronary artery disease, with only 8% relative risk reduction in death and heart failure hospitalization, which was insignificant, but it was observational, and we need to keep that in mind. So I think I would say that the recommendation would be from patient to patient basis. If the patient is completely asymptomatic and revascularized triglycerides and so on, we can consider even stopping the beta blocking treatment. This is something that I'm really interested in right now. It's a growing, exploding field of cardio-oncology, and beta blockers also do have their role in this field also. As you know, we have 2022 cardio-oncology guideline. It's an enormous paper with, I think, a couple of hundreds references behind it. So in primary prevention, in cardiotoxicity, AC inhibitors plus beta blocker were recommended in very high risk patient, especially if they're receiving anthracyclines or anti-HER2 therapy. Namely, this was recommendation for the patients with the breast cancer. You can consider beta blockers or ACE inhibitors in patients with mildly to asymptomatic toxicity, and in the established cardiovascular toxicity with heart failure, and then you need to treat them just like other heart failure patients, especially with reduced ejection fraction. And then you need to treat them with the 4 pillars, as I already said. With the erectile dysfunction, we know that beta blockers can provoke, and they do provoke erectile dysfunction. Nowadays, we do have data that nebivolol could be the most safe in this, but we do know that the nebivolol uses the CYP metabolism and the renal metabolism to excrete. So in some cases, especially in your patients, it could be problem to administer nebivolol. But I think this is not a huge problem. We do occasionally have patients complaining, and we do all of these beta blockers from the slides, patients occasionally, and this is not as common as we thought. So I think they are very safe to use, but sometimes if the patient complain about erectile dysfunction, you can switch from, for example, bisoprolol or metoprolol to nebivolol. And this is not so new. Reactive airway disease, meaning asthma and chronic obstructive respiratory disease. The highly selective beta blocking drugs like bisoprolol or metoprolol are not contraindicated, and they can be safely used in these populations of patients. And this is the special populations of the patients. In the elderly, we should be careful. Sometimes the elderly patients, they tend to have orthostatic hypotension and bradycardia, and usually if they do have indication, we start with the lower doses. With the patients with renal impairment, the bisoprolol is the safest drug because it's not completely renally cleared. And regarding the perioperative risk, if the patient is already on the beta blocking agent, then you don't need to stop it during the non-cardiac operations, but you don't need, and we know that from the Lancet from the 2008, we don't need to de novo initiate perioperative treatment with beta blocking agents because there was no benefit from that. So in these specialties, so if you have a patient undergoing non-cardiac surgery and prior treated with beta blockers, continue but do not initiate de novo treatment. So I'm moving a little bit quick because I want to keep on time. These are the open questions, for example, let's say. So the lots of data I just discovered were based from the open label design, because we need to know that open label has its own shortcomings. Sometimes it's also non-inferiority design. So we need probably to do some double-blind real RCTs. Of course, we need to have better homogeneity of our patients, of populations that we treat. I think we need to know about the pharmacokinetics of our drugs, because there is a regional, for example, Chinese patients versus European patients versus South American patients. Then we need to know about metabolism of the drugs. Of course, I already said that there is a regional discordance. And of course, sometimes we have conflicting data and such abyss versus smart decision that we need to investigate a little bit more. So this is my final slide, and I hope that I didn't bother you too long. And my take-home message is, what about beta-blocking agents in cardiology in 2026? There are mandatory drugs in the heart failure with the reduced ejection fraction. All patients should be treated. In the post-MI field, patients with ejection fraction below 40%, they are mandatory. In the patients between 40 and 49, they could be of benefit. In the patients with normal ejection fraction, there is no proven benefit after MI. Of course, if you follow the smart decision trial, you can safely stop the treatment after 1 year of the post MI. In hypertension field, you should also take to your clinical decision making the regional discrepancies, the resting heart rate, the age of your patient. But if you strictly look at the American and European Society guidelines, these are not the first line treatment for the arterial hypertension. In the chronic coronary artery disease, there is some retained indications, but I think we need to be more critical to the surrounding evidence. And of course, we need to take in counter the pharmacokinetics, regional specificities of our patients, and of course, do some more research and do some meetings like this in order to exchange our expertise and our knowledge. Thank you so much for your time.
Okay, thank you very much, Professor Nikola Bulj, and give us a very excellent presentation and talk about the pharmacology of the beta blocker, about the treatment of the heart failure, hypertension, coronary heart disease, arrhythmia, particularly the atrial fibrillation. And you have already focused on the beta blocker on the Asia population. So thank you very much, and I think probably have time to discuss later on. So I think I'm afraid I think we should move to the next speaker. Then next speaker is Professor Xiaoguang. She is the chief physician professor, the deputy director of the hypertension center of the People's Hospital of the Xinjiang Autonomous Region. And she is a member of the NHC Key Laboratory of Hypertension Clinical Research, the member of the third hypertension professional community of the Xinjiang Medical Association. She is engaged in the diagnosis and the treatment of the secondary hypertension, resistant hypertension prevention and the treatment of hypertension and its related cardiometabolic disease. She has presided and participated in 3 projects funded by the National Natural Science Foundation, over 10 provincial projects. She has published more than 90 research papers. As the leader or main reading expert, she has released 2 expert consensus and contributed to the monograph of the secondary hypertension. So she is, I think she is a very expert in the cardiology, particularly in the hypertension and coronary heart disease. Today, she will talk about the evidence-based benefits of the beta blocks in the standardized treatment of the coronary heart disease. Professor Yao, please.
Good evening, Professor Kong, and good afternoon, Professor Bulj. And today I'm very glad to be here and share the topic as to the beta blocker usage in coronary heart disease. So first, let me share my slides. Yeah. Okay. So is it okay?
It's okay.
Oh,
We
thank
can
you.
see you.
Welcome.
Thank you. Today, my content is composed of two parts. And in this picture, we can see that this is a data analysis from the latest, from the GBD database. And this dark line, it shows the global prevalence of CHD. And we can see that this is the global burden of CHD keeps substantial. And especially, we can notice that this right line, it stands for the prevalence of CHD in low-middle SDI region, which includes China. So these trends emphasize the ongoing and evolving public health challenge of CVD in China, and which strengthens that the preventive strategies and target interventions should be used. And in the next slides, I'll share the epidemiology data from China. The first is about the Agena pectoris. So in the left panel, it's the data from Chinese Cardiovascular Health and Disease Report. It shows that the angina pectoris accounts for 55% in the patient's primary diagnosis with CHD. And moreover, the latest review found that approximately half of patients continue to experience angina at a different stage after PCI. And in the left panel, we can see that the hypertension is the most common comorbidity in CHD patients, and it presented in 61% of cases. The third point is the heart failure. From the data from the China Heart Failure Center registry study, it shows that CHD is a leading cause of hospitalization for heart failure. It takes account 62%. And we know patients with reduced left ventricular ejection fraction have a higher risk of hospitalization and mortality. And it's fortunately in China, the prevalence of heart failure with reduced LVEF is high. It takes account about 1% in Chinese patients with heart failure. And the fourth characteristic is arrhythmia. It is widely known that the target heart for CHD patients is recommended between 50 to 60 beats per minute. But in China, the data shows that the heart rate of stable coronary heart disease patients exceeds 60 beats per minute in over 85% of cases, and exceeds 70 beats per minute in over 50% of cases. And further, the other large-scale multi-center study in China, it showed that over 30% of CHD patients in China suffer from arrhythmias. So from this epidemiological data, we can see that there is really a great burden for Chinese patients to deal with. Then why we choose beta blockers and what makes beta blocker benefit for us? This figure just show a very brief protective mechanisms. We can see that the blockade of cardiac beta adrenergic receptors, it may reduce the heart rate, reduce the myocardial contractility, and inhibit the overactivity of sympathetic systems. And at the same time, the blockade of beta blocker may prolong the diastolic filling time and improve perfusion of ischemic myocardiums. And finally, it could reduce angina episodes and improve exercise tolerance. So currently, the beta blocker is widely used in 6 key clinical situations, which include blood pressure control, heart rate control, and general symptom relief, and secondary prevention and chronic heart disease. And in recent years, beta blocker are preferred first-line therapy at initial diagnosis and long-term use in all stable coronary heart disease patients and in non-STEMI ACS. So in brief, we can see that beta blockers are recommended by main domestic and international guidelines as a cornerstone to treat chronic heart disease, and particularly in patients with angina, with uncontrolled hypertension, and with left ventricular dysfunction and arrhythmias. So in the following slides, I'll show the detailed recommendation suggestions. The first point is angina. It is just like Professor Bulj referred in Europe for most chronic coronary symptom patients. Inhibition of beta blocker and CCB is recommended for heart rate and symptom control. And in China, the guideline of non-STEMI and the guideline on chronic coronary syndromes and the guideline for PCI patients, the beta blocker are recommended to use as early as possible. And besides, the use of beta blocker may reduce the frequency of angina and to prevent exertional angina. The second point is for the uncontrolled hypertension. We may notice that in China and American guidelines for patients with hypertension, beta blockers are recommended as a first-line treatment for hypertension control, especially for patients with hypertension and stable chronic heart disease. There is well evidenced for beta blocker use. The third point is about left ventricular dysfunction. We can see that in China, in American and Europe guidelines, for patients with heart failure with left ventricular ejection fraction less than 40 or less than 50, even less than 40%, the use of beta blocker is recommended to elevate angina pectoris and reduce hospitalization rates and mortality due to heart failure. The fourth is the arrhythmia. We can see that there are some different recommendations about this. In America, for acute coronary syndrome patients without contraindications, oral beta blocker therapy is recommended. But in China, the beta blocker is a class 2 antiarrhythmia agent, and it is used for sinus tachycardia and supraventricular arrhythmias. It can prevent malignant arrhythmias. So in the second part, I will show the latest evidence about beta blocker in coronary artery disease. And the evidence is surrounding the 4 situations just referred. The first is an early study, but it's very typical, the TIBBS study. In this study, we may see from the first left picture, we can see that after bisoprolol treatment, the total myocardial ischemic load in patients decreased nearly 70% compared to baseline. And as well, the number of ischemic episodes and the duration of ischemic attacks also significantly reduced. So it shows that the beta blocker usage can benefit reduce the ischemic, the myocardial ischemic. And the second is also early study. It's a RCT study. In this study, they just compared the isosulfide dinitrate and placebo. It shows that the frequency of angina attacks was significantly lower after bisoprolol treatment. And at the same time, the exercise tolerance after bisoprolol treatment was significantly higher than that after isosulfide dinitrate and placebo. And this is a recent world study in UK, and it compared the beta blocker and the other beta blockers. Meantime, it compared beta blocker with other non-beta blocker agents, which including CCB, ACEIs, diuretics, and alpha blocker, and other antihypertensive drugs. So in the first figure, we can see that compared with other beta blockers, such as metoprolol, tantrate, and carvedilol, bisoprolol significantly reduced the long-term risk of angina pectoris, especially in the fifth years. And the left panel just shows that compared with other non-beta blocker agents, bisoprolol significantly reduced the long-term risk of angina pectoris. Also, it's observed that in the fifth years, the risk of angina could reduce by 39%. This is the latest so let's move to the next point is the hypertension. This is the latest study. It's a meta-study as to the beta blocker use. We can see that the risk of cardiovascular events will decrease very significantly. The benefit derived from a reduction in the average heart rate by 8.2 beats per minute in the general population. The risk reduced 16% for coronary heart disease and 9% for heart failure and 14% for cardiovascular events death. And especially in the left panel, we can see that the average heart rate after acute myocardial infarction or patients with stable coronary artery disease, if their heart rate will control very low, the risk will reduce very significantly. We can see that there is a 21% reduction for coronary heart disease and 18% for cardiovascular disease death. So it indicates that the patients with acute myocardial infarction or patients with stable CHD will benefit more for the usage of beta blocker. And the next study is a ABIS subgroup study, just like Professor Bulj just referred. In this ABIS study from France, the patients with hypertension required long-term beta blocker administration after myocardial infarction. We can see from this picture that compared with patients in beta blocker continuation group, patients in beta blocker interruption group showed a high increase in systolic blood pressure at 6 months. As well, the heart rate also increased significantly at 6 months and still keeps persistently high. And moreover, also the conclusion from the obvious study subgroup analysis, it showed that the beta blocker interruption group have a little higher primary endpoint incidence compared with the beta blocker continuation group, and especially in patients with history of hypertension. And among hypertensive patients, the interruption of beta blocker therapy increased the risk of primary endpoint by 27%. This study is an international multi-center study. It is also include China, South Korea, and Vietnam. This special CAD study also have the same conclusion. It showed that the bisoprolol increased blood pressure achievement rate, and the bisoprolol usage also significantly reduced the heart rate from 75 BPM to 68 BPM. And it's very interesting that we also noted that the lower after treatment with bisoprolol, the lower the heart rate and the lower the incidence of composite cardiac events. So this study indicates that the blood pressure control and heart rate control in patients with coronary artery disease, comorbidity, hypertension will reduce the risk of cardiovascular events. And the third point is about the left ventricular dysfunction. The next informations are from the ESC Congress in 2025 for patients with STEMI and the left ventricular ejection fraction less than 40 who received PCI treatment. The use of beta blocker after discharge significantly reduced the 1 year and 3 year all-cause mortality risk and the major adverse cardiovascular events risk. So will we benefit from the long-term for beta blocker usage? This RCT study gives the answer. The continuous administration of beta blocker for 2 years in patients with left ventricular ejection fraction less than 40 and myocardial infarction significantly reduce the composite risk of all-cause mortality and myocardial infarction recurrence. And this is a very interesting meta-analysis. It is published in last year in Lancet. This study is compared the beta blocker use and non-beta blocker use group. It found that the cumulative incidence of the primary composite endpoint was significantly reduced by 25%. And especially in patients with mildly reduced LVEF, it means LVEF between 40 to 49%. So this study extends the non-benefits of beta blocker for patients to a subgroup of patients with mildly reduced left ventricular ejection fraction. So the study in Korea, also we just referred, provide more evidence. It reports that in Korean people, patients with STEMI and the left ventricular fraction between 40% to 49% who underwent PCI, the use of beta blocker after discharge significantly reduced the risk of death at both 1 year and 3 year, and as well as the miss at 1 year and at 3 year. The late is a tendency study. The tendency study just showed that early administration of bisoprolol significantly reduced heart rate and improved left ventricular ejection fraction and enhanced cardiac function in patients with post-ACS left ventricular dysfunction. In the left panel, we can see that the usage of bisoprolol may decrease the heart rate, and compared with the baseline at the end of 1 year of treatment with bisoprolol, the heart rate significantly reduced from 85 to 76. And meantime, the left ventricular ejection fraction increased from 41% to 48%, which is significantly and the fourth part is arrhythmia. It is well known that for the patient with for patient after coronary artery bypass graft, CABG, the arrhythmia is very common. So in this meta-analysis study, the beta blockers may significantly reduce the incidence of atrial fibrillation and the superior ventricular tachycardia. We can see that the OR value was low, and it indicates that the beta blocker use may decrease the risk of arrhythmia about 50% after CABG. And this slide just show the bisoprolol and the metoprolol. In the left panel, it showed that compared to the metoprolol, bisoprolol significantly reduce both the heart rate and the maximum heart rate. And in the left panel, it showed that there was no significant difference between the adverse events incidence between these two groups. And it's in this both RCTs and real world study we have just referred before, it demonstrates that bisoprolol can significantly reduce the incidence of arrhythmias in patients with coronary heart disease. This panel is the comparison between bisoprolol and carvedilol. It showed that compared to carvedilol, bisoprolol is more effective in reducing the incidence of atrial fibrillation after CABG. And in the right panel, the data also from a 14-year real-world study in the UK, it indicates that bisoprolol significantly reduce the risk of arrhythmia, either compared with other beta blocker or drugs other than beta blocker, which including ACEI, diuretic alpha blocker, and other antihypertensive drugs. So finally, I'll give a very brief summary. China have a burden of coronary heart disease still, and the epidemiology data is still challenging. So it is imperative to strengthen and optimize prevention and treatment strategies. The second is beta blocker is recommended by domestic and international guidelines as a cornerstone medication for both initial and long-term treatment of coronary heart disease patients, especially patients with hypertension. And the third is multiple study in China have confirmed that the beta blocker is used, but it's not enough. So the latest study shows that beta blocker may significantly elevate angina syndromes, reduce blood pressure and heart rate, and improve cardiac function. and control arrhythmias. So these characteristics and benefits make it the preferred clinical treatment for coronary heart disease. So my lecture is over. Thank you for your listening.
Okay, thank you very much. You give us very good talks about the beta block in the coronary heart disease, and you have making very comprehensive summary of the evidence for the use of the beta block in the coronary heart disease. And so thank you again. Now let's move next. Okay, thank you very much. And now let's move to the next session about the discuss session. And in this session, we have two panelists. The first is Professor Guo, Professor Guo, and the second is Professor Zhang. And the Professor Guo, could you please give me an I'm sorry, Professor Guo and Professor Deng. Now, Professor Deng Jincun from the affiliate cardiovascular hospital of the Huanji Hospital, and Professor Zhang from the ATIS affiliate hospital of the Huanji University. And I think this is both these two professors is very famous professor in the field of the cardiovascular disease. And I think today probably we have two topics or three topics. Okay, can share us today? Yes. Okay, so now we have three questions to be discussed. I think the first is for the patients with angina pectoris and chronic coronary syndrome after myocardial infarction. Guideline recommended a resistant target heart rate of 55 to 60 beats per minute for the beta block therapy. And the second, okay, now the question is, what heart rate range is generally targeted for this patient population? What clinical limitation should be taken into consideration? For patients with uncontrolled resistant heart rate, is it appropriate to switch to another highly selective beta block, such as bisoprolol? If a switch is planned, which clinical facts should be prioritized for the evaluation? The second question is, how do we evaluate the clinical role of beta blocks in the overall management of the coronary artery disease? How should we individualize the maintenance duration of the beta block therapy for the post-myocardial infarction patients? The third question is, among the patients with hypertension complicated by coronary heart disease who are appropriate candidates for beta block plus calcium channel block combination therapy? How to individualize the dual tactics of the blood pressure and the heart rate control? And Professor Zhang and Professor Deng, please, who would be the first to make the comments or ask a question or whatever, everything you can. Okay, Professor Zhang, I think I can see you. So now, please, Professor Zhang.
Oh, yes, thank you for having me. Yeah, it's so great to have a discussion with these famous professors. Yes, I think I have many questions like the other doctors in the clinical practice. For the question one, for patients with angina or post-myocardial coronary artery syndrome, yes, guidelines say the target heart rate of beta blocker at 55 to 60 beats per minute. First, it is feasible to lower heart rate down to 55 BPM in real practice. Yeah. I think the answer is yes, because 55 BPM is the lower limit of the recommended target range. If patients remain hemodynamically stable without dizziness, fatigue, hypotension, or symptomatic bradycardia, the heart rate can safely reach the 55. However, I think several clinical concerns must be kept in mind. First of all, first, avoid heart rate dropping below 50 BPM. And second, we watch for bradycardia-related adverse symptoms such as weakness, dizziness, or syncope, or worsen heart failure. So we should pay attention to blood pressure because excessive valve blockade may cause hypotension and reduce coronary perfusion. Fourth, comorbidities matters, including sinus node dysfunction, atrial ventricular conduction block, several peripheral artery disease, or asthma. For these patients, if aggressive heart rate reduction procedure is taken, it might be take more risk for the patient. Then when metoprolol fails to achieve heart rate control and we plan to switch to bisoprolol, what should we assess? We should first evaluate the resting heart rate and symptoms. Second, we also need to check blood pressure tolerance. Then we also need to consider beta-1 selectivity. And bisoprolol has higher beta-1 selectivity compared with metoprolol. We also need to review cardiac conduction status, baseline renal and hepatic function during medication switching. Gradually dose titration is required with close monitoring of heart rate and blood pressure to prevent bradycardia or hypertension. Then question 2, I think beta blockers are a cornerstone therapy for coronary artery disease. They reduce myocardial oxygen consumption by lowering heart rate, blood pressure, and myocardial contractility. They also release angina symptoms, reduce recurrent ischemia, and improve long-term prognosis. For myocardial infarction patients, it is very essential to use beta blocker to reduce mortality and sudden cardiac death risk, especially for those patients with arrhythmia. And they also work well in patients combined with heart failure or hypertension, but they are not suitable for patients with severe conduction disorders or asthma. Then for post-myocardial maintenance duration, we cannot apply a one-size-fits-all rule. For patients with left ventricular systolic dysfunction, a long-term, even lifelong beta blocker therapy is generally recommended. Because for patients with preserved left ventricular function after myocardial infarction, we also need to assess risk factors like ongoing angina, residual ischemia, arrhythmia risk, and comorbid conditions. Low-risk patients may consider gradually dose reduction after 1 to 3 years of stable follow-up. And high-risk patients should continue long-term treatment. Clinical symptoms, heart rate, and blood pressure should also be regularly reviewed for individual adjustment. And for the third question, in my point of view, I think the suitable population includes several groups. First, the patients with coronary artery disease and hypertension who still have persistent angina despite single drug therapy. Second, the patients with elevated resting heart rate, needing both blood pressure lowering and heart rate control. So patients with vasospastic angina and calcium channel blockers release coronary spasm, while beta blockers control myocardial oxygen demand. Both the patient with hypertension and coronary disease who cannot reach target blood pressure on normal therapy. We also need to avoid this combination in patients with advanced atrial ventricular block, severe bradycardia, or decompensated heart failure, because the two drugs may have addictive inhibitory effects on heart rate and conduction. But for those who have been put on pacemaker, it is not prohibited, because the pacemaker is very safe for those patients with these problems I mentioned above. And for individualized dual target management, first we set clear goals. For most coronary hypertension patients, blood pressure target is below 130 over 80 mmHg, and resting heart rate target is 55 to 60 BPM. And second, we should start with low dose combination, especially for those who have a symptom of heart failure. Then titrate step by step, depend on the patient's reaction. And third, differentiated patient phenotypes for patients dominated by ischemia and tachycardia. We should give more weight to heart rate control for those with prominent hypertension, or adjust blood pressure lowering intensity accordingly. And fourth, monitor resting heart rate, blood pressure symptoms, and conduction function during follow-up. Avoid excessive bradycardia or hypertension. Comorbidities such as renal function should also be taken into consideration. To be clear, to conclude, beta blockers remain essential for coronary care. Heart rate targets should be balanced with clinical tolerance, especially for those who have bradycardia, and we need also medication switching and combination therapy require careful individual assessment, and we also need to need a maintenance treatment duration after myocardial infarction, and because it should be risk stratified, and dual blood pressure and heart rate control brings better outcomes for hypertension coronary patients. Thank you. That's my my discussion view for this topic. Thank you.
Okay, thank you very much, Professor Zhang, and he discussed the three questions in details, and having very good comments on these three questions, and so thank you again. And how about Professor Deng? Are you online? Okay, thank you very much, Professor Deng, please.
Okay, thank you very much, Professor Kong, and thanks, Bulj and Professor Yao for the excellent presentation. So, please allow me to apologize that Professor Guo is currently performing an emergency procedure, and therefore unable to join us at this moment. And he asked me to attend this session on his behalf and participate in this discussion. So, I've learned a lot from the presentation before, and for these three topics, I just give my own opinion. So the first is that let me see the first topic. Okay. So the first topic I think is for patients with angina or chronic coronary syndrome. After myocardial infarction, I would consider a resting heart rate of 55 to 16 beats per minute to be an ideal target. However, this should not be regarded as a rigid target that every patient must do it. So in our clinical practice, I think it's more important to ensure that agenda is adequately controlled without causing symptomatic bradycardia, hypertension, or fatigue, or reduced exercise tolerance. Therefore, if patient's heart rate is slightly above 16 beats per minute, but his symptoms are well controlled, and hemodynamic state is very stable, I think there is no need to increase the dose of beta block to reach this kind of target, I think. And the main clinic limitation, I think, include baseline blood pressure, and also is whether there is sinus node function or AV block, or obviously reduce the infection fraction, or also sometimes patients with COPD or other disease. I think especially the elderly, the very old patient, maybe there's for many of them the blood pressure is lower. So for this kind of patient, or maybe we can reduce our target of heart rate, and I think that should be is more suitable. And if for some patients the heart rate is control is not ideal or not enough, I think change it to bisoprolol is, I think, is reasonable. Because as we know that bisoprolol is a high selective beta-1 selector, and also has long duration long duration, maybe about 24 hours. I think maybe is more suitable for heart rate control. However, I think even is high selective beta-1 selective. I think that we cannot just change the medicine from metoprolol to bisoprolol only because of its heart rate is not under control, or not our target is about 55 to 60 beats per minute. So if we want to change the medicine, we maybe think first we need to consider about the patient blood pressure and the baseline heart rate, and whether it's atrial fibrillation or and the PR duration or infection fraction, and neural function, and whether there's also use other medicines that could reduce the heart rate. So before we change it to bisoprolol, we need to think about this. And also maybe we need to reduce at a low dose with carefully, and close monitor the heart rate and the blood pressure. Okay, that is the first question. And the second question is that the role of the beta block over management of coronary artery disease and the duration of therapy after myocardial infarction. So, in my opinion, I think we need to distinguish between symptom relief and improve the outcome. I think it's quite different. It's two aspects, and for symptom control, I think beta blockers remain as first-line therapy for a patient, and the reduce heart rate and also reduce the myocardial contraction. So it can decrease myocardial oxygen demand, so to improve the symptoms. I think it's also the first line and is cornerstone of the therapy of this kind of patient. However, even with SAS patient, for MI patient, and even the within the 24 hours, I think it's still need for recommendation of beta blockers, so to reduce the risk of re-MI or ventricular arrhythmias. So for other aspects, that is improve outcome. I think if outcomes that it is very impressive that Professor Bulj introduced that the update of 2026 that for patients with EF is at least 15%. For this kind of patient, if we give him beta block long term, maybe cannot improve the outcome. And another is very interesting that the recent study shows that if post MI more than 1 year, maybe we don't need to use beta block anymore, because it cannot improve the outcome significantly compared with no beta block. So this is very interesting, I think. So after 1 year, maybe it tells us that it is important to perform echo for patients to evaluate the EF. So this is important for the individualized therapy. Okay. The third question is that combine beta blocker with calcium channel blocker and achieve dual blood pressure and heart rate target. So for this question, in my opinion, the combination of beta block and CCB maybe is suitable for patients with both hypertension and angina. So especially for the patient is blood pressure. Blood pressure is not controlled, and also or has angina for this kind of patient. Both these two patient could to control the symptoms. Okay, but usually we don't recommend use beta blocker with some medicine like verapamil or other disease that could reduce the heart rate or to slow or to infect the AV blocker, AV node conduction. So this is not recommended. Okay. Especially for the patients with reduced EF. So for dual blood pressure and heart rate management, if the patient can tolerate, maybe we pressure to control the pressure to approximately maybe 120 to 130 or 17 to 18 or this kind of blood pressure, and especially for some patient with elderly patient, or he's very weak or he has also has low pressure, and this kind of disease or COPD or some kind of patients, we need to avoid to too much and to axis to reduction of the blood pressure. Okay. For heart rate control, I think that okay, the resting heart rate, the target is also about 55 to 60 beats per minute. Maybe ideal target in patients with angina and sinus rhythm. However, this target should also be used if the patient with no blood low pressure or no other symptoms such as syncope or fatigue or such of this. Okay. If we want to adjust the medicine, maybe for a patient, if some patient with individualized, if he has high blood pressure, but the heart rate is better, is good controlled, maybe we maybe you use the CCB first, and if there's both blood pressure or heart rate is high, maybe I prefer to use more beta blocker. So this may be better for this kind of patient. Overall, combine both these beta blocker or CCB should be individualized, and different patient may be different, and also that from these sections it appears that maybe when we choose medicine in our clinical practice, we maybe need to think more carefully about which patient benefit most, and also to how to select the appropriate agent and dose, and how long treatment should be continued. I believe all these aspects need more attention in future practice. Okay, thank you. Thank you very much.
Okay, thank you very much, Professor Deng. Give us a very discuss these three questions very carefully. And so, how about the Professor Nikola Bulj? Do you have any comments on these two panelists?
I enjoyed listening to this. I really enjoyed it. Listen to our colleagues. And if I may, I would like to make just one or two short comments. I really liked the presentation followed by my own, because you showed your own data and your own guidelines and your own experience. And I think the one thing was very important and underlined when we are talking about coronary artery disease, and it was shown on some of the previous slides. Sometimes the researchers do neglect the extent of the coronary artery disease. It's not easy if you have single vessel disease with one or two stents, or multi-vessel disease, or microvascular disease. I think it should be also encountered into the clinical decision making for our patients. That's one point. So if you have a patient, for example, with the triple vessel disease, with multiple lesions, with high arrhythmia risk, I think that the usage of beta blocking agents is very, very advisable regarding of current status of the data available. If you have a single patient, single vessel disease, which is completely revascularized and completely asymptomatic patients, okay, then we can discuss to even stop the treatment. When you compare the ABIS and the Korean trial, if you look only into myocardial infarctions and the deaths related to myocardial infarctions after 1 year stop off of beta blocking agents, there was no difference. So in regarding to that, we can maybe in the very stable patients, truly asymptomatic patients, we can reconsider the long-term treatment. And regarding the 50 to 60 beats per minute, I think it's completely okay to do it. We do also do it, and bisoprolol is excellent in achieving this goal, but only with one a little caveat. If you have a patient with severely deteriorated left ventricular function, I think it's better to be close to 60 than to 55, or even a little bit more above the 60, 65, for example, because you want to maintain the minute volume of the patient's heart. And these patients, if you slow them too much, tend to be hypotensive and symptomatic. This is my personal opinion in clinical practice. And from Croatia perspective, we do administer highly selective beta blocking agents to our COPD and asthma patients, and we haven't seen any worsening of these conditions. And these are the comments from my point. Thank you.
Okay, thank you very much. And as you know, the beta blocker is the most widely used medication in the field of the cardiology, and I think I personally think that probably almost all the cardiovascular diseases can be treated by the beta blockers. So
I agree.
Yes, but the situation right now in China, I think it is. I still have some worry. For instance, the dosage of the beta block in the treatment of the heart failure, I think the dosage is not enough, and the duration of the beta block use is still, I think, it's too short. So I think we still have many things to do. For instance, to let the patient be the maximum dosage of the beta block, and we have enough long time use of the beta block in the patient with the coronary heart disease, heart failure, and whatever. And for the hypertension, I think in the United States or in Europe, probably the beta block is not a first-line medication for the hypertension. And
No,
but
not
in
anymore.
China, but in China we still have the I think our guideline has clarified the beta blocker as the first-line medication for the treatment of the hypertension. I think that should be a little bit of difference. And do you? I have a question to you, Dr. Nikola, Professor Nikola. As do you agree the Chinese guideline or the American guideline for the use of the beta blocker in the treatment of the hypertension?
I'm a little, so we are talking about, I think I'm a little bit prone to be on Chinese guidelines, because I do think that if you have patient, for example, in his mid-40s, working every day, busy schedules, and it's not the same type of hypertension like the retired person in his mid-70s, for example. One, on the first side, you have the overreactivity of the sympathetic nervous system, and in the other case, you have the stiffness of the blood vessels and everything. So I do like the fact that your guidelines consider this. So I do think that the resting heart rate, I do have the smart ring also measuring my heart rate at the rest and during the sleep. I think it is important. We do know that people with sleeping high heart rates and baseline heart rates which are elevated, they do have some cardiovascular long-term complications. So I think that your guidelines are I think it's more clinically oriented. If you have a patient in your mid-40s or mid-50s and isolated hypertension, you will usually discover these patients by diastolic elevations of the blood pressure, because they do have also diastolic hypertension, unlike the older ones, which are clearly systolic hypertension. I think that in these populations, sometimes, and that's my clinical opinion and experience, sometimes you can use the single beta blocking therapy in order to treat the hypertension. So when comparing, I think that the Chinese guidelines do allow the colleagues to be more flexible in regarding to treating our patients.
Okay, thank you very much. I think probably we have,
but it's my personal opinion. So
okay, thank you very much. I think we just discuss about the use of the beta blocker in the cardiovascular disease, I think. So thank you very much. And I think the time is, we have over 6 minutes for the scheduled time, I think. So so I'm afraid probably we should close this close this webinar, I think. And thank you, Professor Nikola Bru. Thank you, Professor Deng, Professor Zhang, Professor Yao, and give us a very good presentation, and this evening or this afternoon as in Korea. So I think I personally think that probably have many things to think about the use of the beta blocker in the field of cardiology or in the cardiovascular disease. And actually we have many experience with the use of this beta blocker in the cardiovascular disease. And so probably we can find much more our own experience and much more randomized clinical trial. I think that the evidence of the use of the beta blocker in the field of the cardiovascular disease. So I think thank you thanks Asian Heart Society and the Beijing Society of Cardiology and the CDQI by the Chinese Society of Cardiology, and thank you all colleagues to organize this this meeting, this webinar. And so thank you very much, and have a good night, have a good day for everybody who on the line. So thank you. And I think now we end this webinar. Okay, thank you. Bye-bye.
Thank you.
Thank you.
Bye.
Bye.
Thank you.